So I'm here at the National Hepatitis Conference, the 4th National Hepatitis Conference being held in Kuala Lumpur in Malaysia. It's been a very exciting first morning, and there's been some very important announcements which will make a big difference to the approach to hepatitis C management in Malaysia in particular, but have implications for models of hepatitis C treatment in our region and in fact globally. So I'm lucky to be joined by 3 of the people who have been centrally involved in the hepatitis response so far in Malaysia. And so what I'm going to do, if I can move through and ask you each to introduce yourselves and then to give your perspectives on the announcement that's been made this morning by the Deputy Minister for Health, and then to talk about what it means for Malaysia.
I'm Dr. Rosaida, binti Haji Mak Said. I'm working as a consultant physician and a gastroenterologist and hepatologist in Hospital Ampang, one of the hospital with a gastro and hepatology unit in Selangor. I have been working with this hepatitis and area since 2000.
Yes.
When I start my gastroenterology training.
Mm-hmm.
So I have been one of the working group in bringing up this hepatitis, and I have been starting this hepatitis initially as a symposium, a small one as the first one in a hospital level.
Yes.
And the second, third, and fourth as a national and become bigger.
Yes, well, more than 600 people here today, I understand,
yes.
From all over Malaysia and in fact the world. We've got many people from around the world. So I wonder if you could just take me briefly through the announcement that was made this morning and what you think that means for patients here in Malaysia in particular.
I think it's a very good move because all this while the treatment all based on the hospital level. And following this, we were going to be decentralize the patients the treatment to the clinic kesihatan or the health clinic. What we will do is, with the cooperation from FINE and the NDI, we have these studies trials where the POCT will be done at clinic kesihatan. Once they are diagnosed positive, they will refer to our hospital. And during the first visit, we will do the viral load testing. If positive, the second visit will have the genotyping, and during the third visit, we will treat the patient either using the Sampath or Ravi, using the DNDI treatment, or we use the government compulsory licensing with the Sampath and Dakla Tasbir. So what we'll do is, how we'll do decentralize the patient now is, if the patient is eligible for the NDI study, the STORM 2, we will recruit in the hospital. But if the patient is not cirrhotic and very simple, and not eligible for the NDI study, then we will send the drug together with the patient back to the family medicine specialist to treat at the health clinics.
So really shifting that focus of care for people who don't have complicated needs back to primary health care centre. And the announcement or the discussions today around how the treatment is going to be provided free in the public system under the auspices of this compulsory licensing that Malaysia has pursued.
If it's a health clinic, treated in health clinic, the patients only have to pay $1 for registration, but in hospital, they pay $5.
$1 ringgit, isn't it? $1 ringgit. So it's like 30.
You should use dollar.
Yeah.
So
So
say dollar, but it means a ringgit.
ringgit. So it's like in Australian terms about 30 cents, something like that.
Yes.
So amazing initiative.
Yes.
And so if I might then proceed to yourself, please.
Sure. I'm Sampath. I'm here representing FINE. We work with an NGO based in Geneva, but work on developing diagnostics and making diagnostics accessible around the world, especially in the resource-limited settings. And so we're excited to be part of this because, again, the announcement today about decentralization, we work on the diagnostic decentralization, which is a really good partnership. And again, the idea is if it's a test and treat approach, you want to find the right patient population and then get them into the treatment, treatment of the clinical care piece of it. So we feel that diagnostics is sort of the critical piece in identifying the patient at the lowest possible level at the primary healthcare center.
I mean, it is such an important issue. I think a lot of the focus has been on drug pricing. For many years, people have been talking about the price of DAAs, but the price and accessibility of appropriate diagnostics seems to have been lost in that argument. And without testing someone, you can't treat them.
Exactly. That's been sort of DNDi and FIND sort of were formed around the same time with the same idea in mind. FIND being the exclusive sort of diagnostic side of the world,
Yes.
DNDi doing the drug side. So what we have focused on is championing this, tuberculosis, malaria, and so on. Now, sort of in HCV the same way, is to make these rapid diagnostic tests that are really accessible at the, like in this case, the primary healthcare center and Clinician, I believe the name.
Yes.
And so trying to get them to all these distributed centers so we can get where the patients actually meet the first point of contact. And it can do simple but quality assured rapid diagnostic tests. You can actually, it's not just a coin toss, you're actually believing the test that you're getting.
It's reliable.
And then that takes you into the second arm, which then goes into confirmatory testing and which, whether you go into the DNDi trial or the government treatment and so on. So it's a critical piece of this. The other piece that we're also working with, sort of the treatment action group, is to bring awareness and education such that the diagnostics is not just something that's passively done, but there's an active both community as well as healthcare worker training and bring the education level for the information content that the diagnostics is important and the value role it plays.
So really looking at demand side as well.
At the demand side to make sure that this is something front and center, especially given the free treatment.
Yes.
So we're trying to get this across 45,000 patients. That's really the aim of this particular study.
Well, it's a huge opportunity.
It is a great opportunity.
Yeah. And you've mentioned DNDi, so I might introduce Jean-Michel as well. So Jean-Michel, if you'd like to talk a little bit about your organisation's work in this space.
Absolutely. So I'm Jean-Michel. I'm the head of DNDi in Southeast Asia, so based in Kuala Lumpur, and involved in this project from the beginning. So what I find interesting about what we've been able to achieve with our partners here is we started the conversation on a research and development project. At the same time as the Malaysian government was thinking, how do we treat all our patients? We didn't really have the intention to be or plan to be where we are here today. So we started a conversation on research and development, which the Malaysian government was very interested in, just for pure research and development. And as we started, I think opportunities came along. So we were very opportunistic together with the Malaysian Ministry of Health. And then we brought in FIND. We started talking about test and treat. We also started talking about local production, the transfer of technology. That's part of the package of this program. And that's quite interesting also for the Malaysian government, for the Malaysian economy, to think that eventually they are going not just to produce the drug here, because it's not a big market, but learn how to produce maybe a more complex medicine than they were used to produce. So we brought that in. We also have all this communication now with the civil society, but also we've had a fairly active mass communication engagement, social media engagement to promote the work of the Ministry of Health and this exceptional access to treatment. So again, we have over the years, the months, piled up the different components of what essentially is a successful program in a very organic way and in a very successful way. And I think that is what is remarkable here. Of course, it only happened because there was a strong political leadership from the Ministry of Health. Very strong.
That came through very strongly.
Absolutely.
Yes. And just sort of that multilateral partnership that's been drawn together from NGOs, from clinicians, from in fact pharma, and discussing the role of local pharma companies and that sort of information and expertise sharing from particularly Egypt and their model, which we've heard a lot about today. But then the very strong, and it had to be strong, leadership from the Ministry of Health, both from the previous administration and from the current administration, in the face of what was quite substantial pressure from, I think it's fair to say, overseas originator pharmaceutical companies that were really not supportive of the compulsory licensing that Malaysia has used as an instrument to try and get access for people in an affordable way.
The pressure is still there. I've no doubt about that. But yes, and the outcome is unique in the sense that we might have a situation, it's not there yet, but soon, I hope, where Malaysia has actually 3 pan-genotype treatment available in a way or another, using all the form of licenses available. Voluntary license, a simple license that applies for the Rabidasvir or the other drugs from Gilead, or the compulsory license. And that's unique combination in the region. Malaysia is the only country where the middle income country, even low income country in Southeast Asia, where the cost of treatment is around $300 US. Everywhere else, we are closer to $1,000 US, which is still too expensive to implement a public health approach.
Sure.
$1,000 US in Laos, in Cambodia, in Vietnam, that's way too much. And so, 3 pan-genotype treatments around that price, it's exceptional.
It's a huge opportunity.
Huge opportunity.
Yeah.
And that only happened because there was willingness from the Ministry of Health and the government to look at public health, to look at patients, and to fight for them.
Yeah. Well, it's fantastic, and I think that's a great point to sort of finish up on, is the role of patients and people who are affected by hepatitis, and that came up in the sessions this morning as well, about the importance of having the primacy of the affected community represented in when we're designing these policies, that people affected with hepatitis need to be there at the table, reflecting that experience. So if I might finish up by saying, what's Malaysia's next big challenge? Now that this announcement's been put forward, what next for Malaysia?
Okay, the challenge is to get the patients to come forward to us, and once we diagnose in KK, and to come forward to get the treatment. The problem is most of them are from PWID, and most of the PWID refuse to go to the hospital to get the genotyping environment.
Okay, so again, I mean, in all of our countries, unless we design systems and
People
approaches,
so
the people in jet drugs in particular as a priority population, and make sure the services are appropriate for them, accessible to them.
And I think that's where the whole, public awareness and building awareness. This is really ultimately it's a curable disease.
Yeah.
Why not take advantage of the curable disease and really getting that message across?
It's so true. It's so true. Well, I think Malaysia certainly is now one of the countries that's on track to eliminating viral hepatitis in line with the WHO recommendations and guidelines that have been issued. So it's great to have another country showing leadership and to provide an example for other countries in our region and indeed globally. So I'm looking forward to the rest of the conference. Thanks very much.
Thank you.
Thank you.
Thank you.
Thank you.